And I thank everybody. I've got the nice job of summarizing the day, which is impossible. But the impression that I would like to leave with you is one of, on behalf of the steering committee, this has been a fabulous day. I've had a number of people come up to me and sort of had this glow about what we've said to each other and learned from each other. I don't think it's all been synthesized quite yet. But just to run back over the day very quickly, we started with examples of learning healthcare organizations, and we also talked about the aspirational nature, the fact that we learn from our mistakes also. We then went into a key discussion about the value proposition, and waste came up as a very easy target, but also the issue of knowledge markets and management, and the discussion we just had actually bordered on that area as well. We then talked about sustainability, and we talked about the economic case for sustainability and emphasized the importance of partnership with patients and with the Office of the National Coordinator as far as long-term sustainability. We then got into oversight, and if there's any one area that probably needs a lot of immediate attention, it is the area of oversight and regulation, where we have tremendous inconsistency. And I was thinking, what we're seeing in oversight is actually people shopping around for the most friendly IRB, or a director of a research institute finding the most friendly chair of an IRB. That's not good. And we need to make that situation right. Our last session then was about governance, and I thought that was a fabulous discussion. And I like the way Mary challenged us with this notion of 80% of her time is on improvement, operational improvement, not on research. We're trying to bring those together. And Russ's question at the very end, I think, emphasized how important that's going to be to PCORI. Tomorrow, we're going to talk about stakeholder culture, and from many perspectives, and we're going to have two summary statements. One summary statement, or panel, if you will, talking about the importance of CEO leadership and how we're going to make that case for getting on the bus. Have we begun to make that case today, and can we do more of that tomorrow? And then, of course, there'll be the usual summary and next steps that Joe and I and others will do. But since Jim brought up the idea of PCORI discovering how it's going to operate, I think Joe should have the last word here.
Try to make the case that we thought about that in advance. Well, I'm going to be very brief. I was also on the planning committee, and we were enthused going in. I mean, our planning committee meetings were exciting, in fact. And but I think it's true that consistently the speakers today really exceeded my expectations, and they tied together nicely. But mostly, it showed that all of you had thought a lot about this before. I also want to commend everybody and thank everybody for staying. This room is nearly as full as it was at 8:30 this morning, and that's remarkable. Two things I want to say. One is about patient-centeredness, bringing patients and members and enrollees, or whatever we call them, however we think about them, depending on our vantage point, into aspects of the research decision-making process, the prioritization, the choosing of topics, the conduct of the research, the implementation of the research was mentioned in every panel today. We didn't really, we weren't here when PCORI was named. The rendition I've gotten from those who were here was that there was not great thought put into naming PCORI. They just didn't want to name it the Comparative Effectiveness Research Institute. And there was patient-centered care. There was customer centricity in other fields. It had made it over to healthcare. I just learned today that Don Berwick is maybe credited with the term patient-centered care. Certainly that came, a lot of that came from here in the IOM as well. But I couldn't help thinking in every single presentation this morning, what if the patients were more involved? And I've got to talk to Barbara afterwards, because in the area of oversight, regulatory oversight, when researchers at any level go to the IRB or to OHRP, in a certain sense, they're suspect. In a certain sense, if your view of your role is to protect from who is the next question, and here are the people that you are protecting patients from. So you're one down going in, and I couldn't help asking myself, shouldn't patients and couldn't patients and wouldn't patients make a tremendous difference? And isn't there really, if we're doing patient-centered care and patient-centered performance measurement and now patient-centered research, shouldn't we be doing more patient-centered research oversight? And wouldn't it be interesting, maybe even on our merit review panel, since our merit review panels have half patients and stakeholders that aren't researchers, wouldn't it be good for them to render an opinion about whether an informed consent was needed, and what would IRBs do with that? So that whole notion of patient-centeredness in regulatory oversight, I think the last thing I want to say was about governance. Two things. One, I think that member and patient participation in governance decisions about which studies to spend the organization's time and energy on, it would help Brent James. I think it would be an interesting addition to Brent James's prioritization process, and it would be a very interesting, if he doesn't do it already. I don't think I see Brent here right at the moment. I think that patients could help in the prioritization level. And the last thing I wanted to say is to any system leaders, any CEOs, COOs, CFOs, CIOs that are here, with respect to PCORNet in particular and CDRNs, a couple things. Number one, you probably know this, but you might not know this yet, that PCORNet does not envision itself as being a pooling of data. It's a distributed research network where every CDRN for every study makes a decision about whether to participate or not. And that we've always said that governance of the system and decisions at the level of the CDRN are a function of the researchers, but the system leaders and the patients as well. So that's important to remember. And with respect to Russ Waitman's comment about what about quality improvement measures, and reflecting Mary's comments, that has been going through my mind today too, and it's something to take back to the steering committee. We say all the time that our mantra is there has to be something in this for everyone, and we might ask ourselves a little bit better if one of the early wins is actually proving to the systems that there's something in it for them as well. To the system leaders, you should think of it in that way, that there needs to be something in it for you. Please make certain that there is. And since there aren't really people here representing those frontline clinicians, the physicians, nurses, and other pharmacists and others, tomorrow I know we're going to talk a bit about engaging the clinicians, and that really is important. What about those clinicians? We count on them to put the data in oftentimes, and we really hope that they turn out to be users and beneficiaries of this as well. So thanks. It's time for our reception, and then we will see you all tomorrow morning.